Welcome to COVID-19 Updates on Guidance. I am Renat Eppelman, your moderator for this evening, and I am the National Manager of Pediatric Education and Resources of the Crohn's and Colitis Foundation. As we continue to learn about COVID-19, IBD patients and caregivers are having a lot of questions about how it may affect them and what precautions they should take moving forward. With the emergence of the Delta variant, there is new guidance regarding masking, vaccination, and returning to school. Tonight, we will aim to answer questions the IBD community may have about COVID-19, vaccines, and guidance for patients with Crohn's disease and ulcerative colitis. I would like to welcome tonight's presenters, Dr. Freddy Caldera, a gastroenterologist and IBD specialist with the University of Wisconsin-Madison School of Medicine and Public Health. And Dr. Caldera can be found at Dr._F Caldera IBD on Twitter. And Dr. Elizabeth Utterson, pediatric gastroenterologist with the Washington University School of Medicine. Thank you both for joining us tonight.
Yeah, thanks.
Before we get started, let's go over a few quick pieces of housekeeping. The information provided during tonight's chat is meant for educational purposes only. It should not replace any advice you receive from your gastroenterologist, primary care provider, nutritionist, or surgeon. If you have questions about your specific care, please reach out to your healthcare provider. If you have questions about IBD unrelated to COVID-19, we won't be able to get to them tonight. However, to get your question answered, you can contact our IBD Help Center by calling 1-888-MY-GUT-PAIN or emailing info@crohnscolitisfoundation.org. We asked our followers to send in questions in advance of today's discussion, and I will go around and ask our presenters to help answer these questions. I will begin with Dr. Caldera. Dr. Caldera, the CDC has recently updated its recommendations for masking. Can you explain to us what these recommendations are and how it impacts IBD patients?
Definitely, I'd be glad to. I know this is an important topic that personally in my clinical practice, I've seen many of my patients being concerned because it almost feels like we're asking them to go back to the beginning of COVID, and that can be very mentally hard for anybody. So before I answer that question, I think we need to just take a step back and say, who is the ACIP? On what evidence do they make this recommendation? Who are they talking about? Because my hope is by the end of tonight, most patients with IBD will have some reassurance. We have some good data that the COVID-19 vaccines produce antibodies in the majority of patients with IBD. So who is the ACIP? The ACIP is the Advisory Committee on Immunization Practice. This is an independent group that provides expert advice to the CDC. They're made up of medical and public health experts. And normally, when we're not in a pandemic, they provide recommendations for vaccines. So they're the people that decide to what evidence there is for a vaccine and who should it be used in. So at the end of July, they met to discuss, should there be special recommendations for immunosuppressed patients? And because the ACIP is a big organization, they really can't provide specific recommendations for all immunosuppressed groups. So that's where patients with IBD fit in. Because when they state immunosuppressed groups, they're talking about people with an organ transplant. They're talking someone with a bone marrow transplant. They're talking about someone undergoing chemotherapy. And they will also include someone who has IBD who might be on a medicine that is called an immunosuppressant, like the biologics. They gave general recommendations like this because we know from COVID that certain immunosuppressed patients are at risk for worse COVID outcomes. They're at risk for more severe disease. Thankfully, we know from SECURE and other great resources that having IBD doesn't necessarily mean you're at an increased risk for getting a COVID-19 infection. We know that people with IBD who get COVID do not have different outcomes than the general population. And we know that the majority of the medicines we use, like the immunosalicylates, the biologics, the immunomodulators, immunomodulators are not associated with severe COVID, which is really all we care about. And when you hear severe COVID, it means being hospitalized, being in the ICU, or dying. If COVID only caused a mild upper respiratory tract infection, it wouldn't have changed the world. But we know that is patients with IBD who are on steroids are at higher risk, and those with the same risk factors as in the general population, such as those with diabetes, obesity, and respiratory issues. So if you have Crohn's or ulcerative colitis or an ostomy, it doesn't put you at increased risk for a bad COVID outcome. So why did they meet? I'm sure many of you have seen the articles, in the press stating that immunosuppressed patients may not respond to vaccines. So where does this information come from? A lot of this comes from studies in patients who are solid organ transplants that are usually on 2 medications and usually also might be on prednisone to suppress their immune system to make sure they don't reject that organ. And some of those patients have been found to not have a good antibody response to the vaccines. But we have to remember, even in those patients, these are not using the same assays or tests to look for antibodies that were done in the clinical trials originally. A lot of these have been used in commercial assays. And because solid organ transplant patients and other patients who are immunosuppressed are risk for worse COVID outcomes, the ACIP said to protect populations, immunosuppressed patients should mask up and social distance. How much this applies to patients with IBD? I think it applies just like it applies to all of us. Regretfully, Delta is causing another surge. And I personally don't have IBD. I'm personally not immunosuppressed. But when I go out, I also mask up. I have a layer of protection.
Thank you for that overview. It's very helpful. And I know you mentioned this, but Dr. Utterson, if you could go a little bit more into if the COVID vaccines are effective for people with IBD and specifically children with IBD.
Absolutely. So, certainly we haven't had very much time to gather evidence, but some of the studies are starting to come out suggesting that, certainly the kids 12 and up who have received the vaccine have made antibodies, or certainly have made whatever we deem as immunity to this virus. And it's not specific for different medications. It seems to be patients that are immunosuppressed, all different medications involved. So, it's one of those things where we're delighted with this news. We're delighted that, they don't get very sick, we hope, with COVID-19, but it continues to be a big public health problem. And there are certain immunosuppressed patient groups that are at risk. And so we have to do our part to try to end this. And, certainly for us in pediatrics, we're anxiously awaiting the next group to be immunized, which is probably going to be the 6 to 12-year-olds, but perhaps it'll be a few months from now.
Dr. Caldera, is there something that you wanted to add?
Yeah, so I briefly mentioned that, in patients with IBD, we have a lot of emerging data. We have data from the Prevent IBD group, and this is a lot of adult data, showing us that the majority of patients, so in that study, they looked at antibody responses a couple months after the 2-dose series, and they found that 95% of patients produced antibodies. We know from the Corral study led by Dr. Gilmel that getting your COVID-19 vaccine is not associated with a flare. We have early data from the Icarus study that the majority of patients in the small group produce antibodies. We will be presenting some data soon also from our center that is looking very promising also. So I think overall, what I like to tell my patients is that we are seeing that just having IBD, we're not getting any data that patients with IBD would really need boosters, because most of the patients are producing an antibody response.
Great, thank you both. And Digging a little further, Dr. Caldera, are there any vaccine efficacy considerations for patients that are on certain medications? For example, we have received questions from patients who might not be on biologics, specifically 6-MP. Is there anything that that group of patients should know?
So I think when we take a step back and talk about just vaccines in general, so not all vaccines are created equal. And something that I like to talk with my patients about is that, we have very highly efficacious vaccines like our childhood pediatric vaccines, like the measles, mumps, rubella, varicella. They're really good at preventing disease. We have like the influenza vaccine that is really good at preventing you being hospitalized from severe disease. But at times you can have breakthrough disease, where you can still get the flu, and that's where I have to have the conversation. So when we talk about vaccines, and I'm getting there, we have data that just having IBD doesn't impact your vaccine response. Medicines like the thiopurines, like 6-MP and azathioprine, aren't used as often. But we also have a lot of data with different vaccines that they really don't impact vaccine response. Because all these studies are new, a lot of patients are on biologics. Are we able to break down the data on thiopurines versus biologics? We're not seeing that yet because our numbers are low. But as someone who does vaccine research, I don't consider a thiopurine affecting vaccine response. That's what our previous research has shown. So from that, I would hypothesize that if you're on a thiopurine, you should have as a normal response as someone who's on a biologic. Because a lot of the data of, hey, I have IBD and I may have a blunted vaccine response comes from influenza and pneumococcal vaccine studies. And that's where just having IBD and being on certain medicines doesn't mean you're not going to respond to all vaccines. There are some vaccines like the new shingles vaccine that has an adjuvant, and that makes everyone produce, a good vaccine response. We're doing some studies now to see how well it works on patients with IBD. I hope that answers the question.
It does, thank you. And then speaking of vaccines, specifically the FDA, that it is expected that they will be approving the Pfizer vaccine fully next month. Can you discuss, Dr. Caldera, a little bit about what full approval means as opposed to what it currently is approved as?
Yes. So all the current vaccines we have, the Pfizer, Moderna, and Johnson & Johnson, went under an EUA, so emergency use authorization. That has never been done for vaccines. But at the time, that's what we needed. So to get something under an EUA is very different than getting full licensure. Getting full licensure of vaccine can take months to a year at times because there's so much information that's needed. There's 6 months follow-up data that's needed. And we didn't have that at the time of the EUA. So the FDA is working very hard, but when they do a full licensure, they have to examine facilities, they have to examine production, they have to look at 6-month data, that the 6-month data from Pfizer is in preprint right now. Once something undergoes full licensure, now someone can provide the vaccine per their discretion. So under the EUA, there's a lot of question, can you do a booster? Boosters are not allowed under an EUA. Once something becomes a full licensure, the ACIP may decide certain patients may benefit from boosters.
Great, thank you. And Dr. Utterson, I know you mentioned that 6 to 12, that age group will likely be the next approval phase for the vaccines. Are there any updates about approximately a timeline for that age group to get approved and vaccine eligible?
Absolutely. Great question. I think, we had hoped originally that they would be ready for right now as school starts or early fall. But I think they're re-looking at certain things like inflammation of the heart in very rare cases and other things that is going to cause them to be a little bit more cautious to authorize the EUA. And it looks like it's going to take a few more months. Whether that, probably saying winter is probably the best way to say it, just because it's hard for me to say distinctly how many months. But I think, when the EUA comes out, we can feel very rest assured that, they have really looked at these and determined that it's not high likelihood of any problem occurring. And then they can participate in getting these kids vaccinated and protected.
Great. And Dr. Caldera, in terms of vaccination scheduling, are there any considerations that IBD patients should be aware of? Should vaccinations be scheduled around certain treatments or within a certain time frame between treatments?
So I would say no. So hopefully most people with IBD have been vaccinated with a COVID-19 vaccine. If you haven't and you have questions, I spoke to another patient the other day whose whole family had been vaccinated, but they hadn't because they were concerned about a flare. So I talked to them that the data shows us that there's no risk of flare. And actually, we haven't seen a risk of flare for any vaccine. So really, you should get vaccinated at any time with COVID. And as influenza comes in the fall, you should also get vaccinated anytime. Doesn't matter whether it's the day of your infusion, the day before your infusion, that doesn't matter. And make sure you're up to date and talk with your gastroenterologist about, am I up to date with my vaccines? Because my big concern is with telemedicine, I'm concerned, will our immunization rates go down? We've been working so hard. People like, Dr. Freddy has been beating the drum for a very long time about making sure people get vaccinated, that with virtual visits, we want to make sure those go down. So make sure you talk to your gastroenterologist if you're up to date with every vaccine you need.
That's great information for both COVID-19 vaccines right now and health maintenance and beyond moving forward. And Dr. Utterson, a similar question with regards to younger patients who are on certain treatment plans. Should pediatric patients, and especially once they become eligible and it's open to younger age groups, should they schedule vaccinations around their treatments?
So we definitely have the same answer. No, getting the vaccine as soon as you can is what we've been doing, and we've been doing that with success. And certainly it's just, and initially we were worried about patients on prednisone, and so we tried to get them off prednisone before they had their vaccine. But the recent data has shown that even patients on prednisone are making a response. So we just want people to get protected as soon as they can. In our hospital right now, we're allowed to vaccinate inpatients 12 and up. But it hasn't moved to the outpatient sector, and I think that'll deal with the final approval from the FDA.
Great, thank you. And Dr. Caldera, I know you mentioned this earlier, but there has been some discussion of potentially needing a booster shot in the future for COVID-19 vaccines. Can you discuss a little bit about what we know so far and if IBD patients may need a booster shot in the future?
Yeah, I think that's a very popular question that I think, just so people know, on Friday, we'll be getting more information. The Advisory Committee on Immunization Practice will be meeting again. And just remember, when they provide recommendations, they're grouping all immunosuppressed patients. So if you hear something Friday that they might say, hey, they're probably going to tell the FDA, this is what we would like to see before we would recommend a booster. All last year at those meetings, they started talking about how a vaccine was going to be allocated, who should be doing it. So the ACIP is a great group. They're going to be proactive. And I think what they're going to talk on Friday is say, who should we consider boosters in? What evidence do we need before we recommend a booster? Because we need the science. When we talk about patients with IBD, if we're seeing the majority of patients producing antibodies, if we're not seeing breakthrough infections, I think patients with IBD may not need boosters. If there's someone with IBD who has an organ transplant, that's a different story, and we'll need more evidence. But I think we'll need at least some science of safety and what a booster does before the ACIP gives a full recommendation of people should get boosters.
Good to know. And Dr. Utterson, as schools start to open up both within a few weeks and now and over the fall, can you provide some recommendations on masking and other precautions that parents can take for their children with IBD returning to school?
Sure. I think this is a hot topic. Certainly, some places really want the parents to be able to make the decisions. Other places are trying to kind of intervene with what they think is right. The CDC recommendations do talk about masking and social distancing. And we do have to think that this occurred very successfully in many schools, at least in the spring semester of last year. It's one of those things where I think they did it quite well, quite gracefully. And going back to that can help us to assure that our students can stay in school, because we think that better learning goes on. We think that better socialization, obviously, goes on. And we just want as much normalcy as we can. I think, we know that fully vaccinated people can be infected with the Delta variant, not be very sick, but certainly give it to other people. And so, certainly I know that not all schools, some colleges are starting to say that they have, they mandate that there's proof of vaccination. And, certainly I think they're going to all come to their different thoughts regarding that. But I think the CDC guidelines to follow with masking, social distancing, and some of those techniques we know have been very effective to this day, should be employed to keep our kids safe.
Great. And you talking about the Delta variant actually leads into our next question. And we know that this variant has been reported as the predominant form of the virus in the United States. Dr. Caldera, can you talk about what this variant is and why we're seeing more cases? And how can IBD patients protect themselves and stay safe?
Yes. Yeah, so the Delta variant is thought to have originated in India. And, we all probably remember hearing news of how India was doing, then went to the UK. And a lot of the data of what the Delta variant is, how efficacious we have from the UK. And a recent study published in the New England Journal, just published at the end of July, shows that our current mRNA vaccines, we're waiting for more data on the Johnson & Johnson vaccine, show that those vaccines still work very well. They were protective against symptomatic disease 88% of the time. And then to protect against severe disease. So remember, when we're talking about severe, we're talking about hospitalization, being in the ICU, or dying. They're still highly efficacious in the high 90s. So these vaccines still really work. The reason that we're seeing a surge again is mostly because Delta is being spread by people who are unvaccinated. That's who is the majority, and there's thought to be higher viral loads. So in a way, it becomes more infectious. So if you look at states that have lower immunization rates, those are the states that you're seeing have more issue with Delta. I know some patients have told me, well, I heard of someone who was vaccinated and they still got COVID. And then they hear the CDC recommendation. So the CDC is not saying mask up because the vaccine doesn't work. It's saying, let's mask up because now we have a different layer of protection. We're learning all these new terms with COVID, right? Quarantine, layers of protection. I'm vaccinated, but I'm gonna wear a mask to make sure that even though breakthrough infections are rare, I don't also become a spreader. And that's what we're trying to do. We're trying to protect everybody. So if you have IBD, this doesn't mean based on the evidence we have that now you have to quarantine. You know, if you're around other people who are vaccinated, the risk of a breakthrough infection is still pretty rare. So if, you know, it also depends on what county you are. You know, if you're in a county that's highly vaccinated and you're around other people, sure, mask up, but it doesn't mean you can't see your family again. You know, I think that's what we have, and our hope is that we just get more people vaccinated to help protect us not only against Delta, but the other variants that we'll see.
Sure. And Dr. Utterson, are children impacted differently at all by the variant, or are there any additional concerns for pediatric IBD patients when it comes to this variant and COVID-19 in general?
Absolutely. Thanks for asking that. It is concerning to us that we are seeing more patients in the hospital with COVID than we did all the year and a half prior to this. We also are seeing more admissions to our ICU. So that's the severe disease that we talk about. And, you know, certainly it's hard because their kids under 12 are not eligible for a vaccine. So, you know, it's one of those things that we understand that happens, but, you know, certainly we want to get as many people that can be vaccinated so we can stop the spread, because we certainly are seeing more kids affected. It's hard to know if it's going to be associated with MIS-C or if it's going to be associated with a lot of cardiovascular complications post-infection. I think that remains because a lot of those things lag after the infection. But I can tell you our hospital this summer has been busier than it's ever been in the summer, not only with, you know, now COVID and presumably the Delta variant, but also other viruses that kind of went dormant while everybody was masking up and staying socially isolated. We're seeing tons of RSV. RSV in July is crazy. So, you know, and I have to say personally, you know, I kind of, when the mask mandates settled down a little bit, you know, I would go to run an errand with my husband and he'd say, well, I'm fully vaccinated. I'm not going to wear a mask. I continue to wear a mask. If nothing else, I want to make sure my patients are protected and our young children at home. But I really remembered listening to Dr. Fauci and having him say, gosh, I think you need to kind of be an epidemiologist. So if you're going somewhere where you know that you're around people in close quarters, or you're inside or even outside with a lot, you know, like a big concert or something like that, that still protection, you know, is afforded with mask wearing. So I personally, and a bit selfishly, I've never been as healthy, I guess, over the last year and a half being in pediatrics. It seems like I like to get various different forms of viruses I've seen before, but just a little different. So I actually have, you know, kind of incorporated it and I have seen not only the utility with COVID-19, but also just kind of general health in the field of pediatrics.
Great. And Dr. Caldera, I know you mentioned breakthrough cases earlier, but is there any other information that you can tell us about breakthrough cases among those who are vaccinated? And what does this mean exactly? You know, are the vaccines still effective? Are IBD patients who are vaccinated still protected?
I guess when we think of breakthrough cases, we have to think that millions of people have been vaccinated. I mean, I was thinking about this question the other day, and I remember, you know, when before COVID vaccine efficacy data came out, and I think anyone would have wished there was a vaccine that was 55% effective, right? We would have taken that anytime. And then Pfizer came out, and you're like, wow, 90. Then you see Moderna, 90. And because we have hundreds of millions of people who are vaccinated in this country, but regretfully, we're in the middle of the surge. The vaccines are still working. They're working about what matters. And that is preventing severe COVID. Sure, does anyone want to get COVID? No. But it's preventing what causes to shut down. It's preventing what overwhelms the health system. So the vaccines still work. the vaccines still really work against severe disease. And that's for my patients where I know I've had this conversation where in a way they almost feel like they never got vaccinated based on if you follow the CDC recommendations. But remember, that's based on data on some transplant patients. So I think right now you should do what everyone else should be doing, is masking up to protect society, to protect our children. Because even though COVID disease is really rare in children, it's not rare for that parent who has that child. So that's what we should do. We should not do it for you, but do it for society.
And Dr. Utterson, you mentioned that you're seeing a lot of cases in the ICU, and overall, we're seeing a lot of cases in children and teens with COVID-19 specifically. Are there any specific concerns for pediatric IBD patients and any guidance for parents on what they should do if their child does test COVID positive?
Absolutely. We've definitely had several of our IBD patients have known COVID infections. And quite honestly, they've actually weathered the storm better than most of the other patients that aren't immunosuppressed. We think that in part that's due to they're taking medications, which are, if you would, dampening their immune systems, not allowing it to get all feisty and out of control. And we think the virus is especially good at doing just that. So I've had patients on Humira who have got the virus that maybe had a fever, maybe to 101, not much higher than that for maybe 36 hours at most. Some who have lost taste and smell, and different things like that. But I think, it's one of those things that, and I agree, certainly there may be some breakthrough infections in people that are immunized, but that has happened to me and anybody who's gotten a flu shot and has gotten the flu. It's not usually as, you're not on your back for 5 to 7 days, not able to function. It's a much more mild version. And it's, important to do what we can to keep our kids safe, especially those who can't be vaccinated yet.
Great, thank you. And as we kind of come to an end tonight, I wanted to know, Dr. Caldera, is there anything else IBD patients and caregivers should know at this time?
I think a common question that I get is, can you check my antibodies? And that is tough because not all tests are created equal. So even when you look at the Moderna, Pfizer, Johnson studies, we all remember Operation Warp Speed. All those assays were done through one center, through the NIH. They were being done the same way. The current commercial tests, most of the commercial tests out there, got an EUA to test for COVID-19 infection. So you make different antibodies if you have a COVID-19 infection versus if you are vaccinated. And the trouble is, since not all tests are created equal, there are some tests that may be better than others. We need a lot more science. And even if you get an antibody response to what we call the spike protein, which is what you would produce an immune response to if you got vaccinated, we don't know what that antibody level means. So there are patients who've gotten, most of people are getting antibody tests through research studies. We have a group where we'll be giving samples and we'll be giving their results back. And if someone has a level of 10 versus someone has a level of 50, no one knows the difference. If the 10 is good, the 50 is better, because we don't have what we call a correlate of protection. And it might not even be antibodies. It might be your T cells, and over time, for all vaccines, antibody levels fall. So if you check someone's antibody at 6 months after they get vaccinated and it's zero, it doesn't mean you're not protected. Our immune system's very complicated and has something called memory B cells that they're ready, if they see that pathogen or that virus, to make antibodies. But none of these are done in commercial tests. So we really just need a lot more research before, because the last thing I would want is someone to check their antibody, get a negative value, and I would be worried that maybe the vaccine never worked for them.
That's a great point. Thank you. And Dr. Utterson, same question to you. Any final thoughts specific to pediatric patients and their caregivers that they should know at this time?
Thank you. I, certainly think that we have enough data about safety of vaccination for ages 12 on up. And I think that, we certainly haven't excluded any populations with IBD from getting vaccinated for any health type reasons. And so, my big push would be while we're waiting to be able to vaccinate the younger kids, probably the best thing you could do for society, for them, is to get vaccinated to stop the spread. And we all want to get back to normal. And I think that's probably the most effective way that we can achieve that goal.
That's a great thought to end on. I would like to thank our speakers for their time and insights tonight, Dr. Caldera and Dr. Utterson. If you have any questions about COVID-19 that were not answered tonight, please visit the foundation website at crohnscolitisfoundation.org and see the top of the website for our COVID-19 specific resources. You can also contact our IBD Help Center by calling 188-MY-GUT-PAIN or emailing info@crohnscolitisfoundation.org. You can also visit the AGA website at gastro.org and look under practice guidance for COVID-19 specific information. If you enjoyed this session and learned valuable information, we do hope you will share this recording, which will be available on our Facebook page and our YouTube channel. We want to continue to serve the IBD community with programs like this and other critical education and support programs that our patients need now more than ever. Thank you so much again to our speakers, and hope everyone has a great night.